Well, hello and welcome to another edition of Health Solutions with Shawn and Janet Needham, where Team Needham discusses everything healthcare. I'm your host, Shawn Needham, along with my producer, Steph, and we are streaming live from the Moses Lake Professional Pharmacy Studio. And I am super excited to have Dr. Josh Leavitt on. You guys do not want to miss out on this. He is not a typical doctor. He's a direct primary care doctor, and we've had doctors like him on here before. And he's going to talk about how he is able, because of that model, he is able to actually help people get off medication. So today we're going to try to discuss how to get off diabetic medication. Possibly we'll get into antihypertensives or blood pressure medication and statins. You guys have heard about cholesterol medications and statins. Josh and I are right on the same page when it comes to that. And that's one of the areas where we have just become good friends when we started talking about that, because not all the time are people on the same page in healthcare when it comes to statins and cholesterol. So I'm super excited to have Josh on. You want to tune in for the rest of the episode so you can don't miss out on anything. And if you know of anybody that is a diabetic, or if you are a diabetic or pre-diabetes, you want to listen up, because Dr. Leavitt is going to talk to you about how to get off your medications possibly. So that being said, although I'm a pharmacist and I'm very passionate about this subject, and Dr. Leavitt is a doctor and he is very passionate about this subject, do not stop your diabetic medication without consulting your healthcare provider first, or any medication for that matter. So please feel free to reach out to me. Please feel free to, later on in the show, we're going to show you how to get into contact with Dr. Leavitt. So Dr. Leavitt, without further ado, welcome to our show.
Shawn, thank you so much for having me on. I appreciate it.
So tell us a little bit about your model of direct primary care, why you went into direct primary care, and how it enables you to take care of patients better and to add more time to their visits.
Absolutely. So, like many family medicine doctors, such as myself, I began working for one of the big companies in my area and was seeing a lot of patients per day and felt a little strapped as far as the time that I could allow for each patient, and really felt like I wanted to give more time and I kind of couldn't because of time restraints and that sort of thing, and documentation restraints, and found a better way. So I found out about direct primary care in 2017, put in my notice to my big company here, and did another 6-month stint with them just as a courtesy for those patients that I had seen for half a decade, and then transitioned over to my clinic, which is called Nampa Direct Care here in Nampa, Idaho, near Boise. So, and as part of that model, I know that you've had other direct primary care doctors on the show, and many of the people who are watching probably know that concept pretty well. But for those of you who don't, it is a monthly membership model where the patient might pay $50 to $75 per month, month in and month out, but then be able to text me with their issues, begin to address them sooner rather than later. They don't have an office visit charge. They don't have a copay to meet. I don't have to meet the insurance's demands of dotting certain I's and crossing certain T's that don't necessarily mean better care for the patient. And so I was able to get out of the, meaningful use sort of documentation program and pleasing, Blue Cross or Medicare, whomever it was, and actually begin, in my opinion, to spend more time with the patients and begin to address a lot of the issues that had to go by the wayside by not having enough time. Now, I do not mean to say that my colleagues who still practice don't do a good job. That's not what I'm saying. But a little more time does go a long way for some very complicated patients. And so I began this business and this clinic to help those patients and actually to have a better quality of life myself as a physician. So I am able to spend now an hour with each of my new patients, whereas before I was lucky if it was 15 to 20 minutes, and certainly had to spend most of my time in the chart, even in those circumstances, with 20 minutes. So being able to spend that initial hour with the person really helps us get to establish a good rapport together. They begin to trust my judgment, which is not the end all be all, but it is helpful, especially with regard to this nutrition aspect that we're going to talk about here in a minute. Building that rapport with your patient and having the patient trust you and you actually trust the patient as well goes a long ways. So now, rather than feeling like every patient who's not succeeding must be non-compliant with their regimen, their medicine, or whatever it is, I feel like I know the people better and whether they're telling me the truth or not. Okay, that doesn't mean it's still not a struggle in many people to follow good nutrition and to avoid problematic nutrition, but it's I feel like it's a better circumstance. It sets us up for success rather than failure. Okay, so anyway, that's my clinic here, direct primary care model, and it does allow me more time with my patients. And during those longer visits or the texting and phone call interactions that we have on a frequent basis, that allows us to really get to the bottom of some issues here. So, with that, I think we could go into the nutrition, because now you know why I can spend a little more time. I rarely refer to a nutritionist or a diabetic educator, and we'll get to why that is, but I do have a few here locally that I will refer to, given not succeeding with my patient and needing even more time with them, which I don't have unlimited time. So I'm willing to spend a lot, but if we're just not getting anywhere, I'm happy to get specialty involved as well, especially the right specialist. So.
And don't you have a little bit of a health story yourself?
I actually do. I did not know you were going to bring that up, Shawn, but I will talk about
Sorry.
it.
Well, I like it because it really, I have a health journey also. I mean, I used to be 60 pounds heavier, and I think it goes a long ways when I talk to patients that are trying to get healthier and eat better. And because I've been there, I've done that. So share your story.
Absolutely. No problem at all. And it's not so, private or personal that I would feel too vulnerable going there. And I've told many of my patients this story about me. So I come from a background of, intermittent exercise and trying to stay in shape and struggling with consistency with going to a gym and that sort of thing. I've also kind of dabbled in different nutrition forms. My spouse, Angelique, was vegan for quite some time. And I was what I call opportunistic vegan with her. And this was in a time where I felt like a lot of the specialists were recommending more of a plant-based, especially a few cardiologists that I followed at the time. And that a plant-based, of course, having been brought up in the era of, animal fat is of the devil, and it's what causes, plaque formation in our arteries, and this sort of, idea. I was one who bought into that. And so I did a pretty much plant-based nutrition. When I talk opportunistic, that means if my spouse cooked something and it was all plant-based, then I was totally for it. Anyway, my opportunistic vegan looked like a Subway sandwich for lunch almost every day if I could get it, or something in the hospital doctor's lounge, because I worked for one of the bigger hospitals and they had free food there. So a lot of it had, and sweeteners in my coffee or tea or whatever, lots of desserts. And it was because I was a slender man who, if he was actually dedicated to an exercise regimen at that time, as a slender individual, could easily get, the modest amount of body fat that was collecting off pretty quickly with the right exercise, and yet could still maintain a relatively suboptimal nutrition plan and still stay slender. I was one of those fortunate individuals, but I didn't feel well. And so I ended up having one of my colleagues test me for rheumatoid arthritis. I had joint pain all the time. I had low back pain all the time. I was burning the candle on both ends, charting at 3-4 o'clock in the morning, staying up till I was, till all hours of the night sometimes as well, because I was not a super proficient, novel writer in clinic. I like to spend time with those patients and do less documentation while I was with them. But so I did a lot of after hours type stuff when I worked for the big hospital company. So I also had my testosterone checked because of the fatigue and because of all that. And I should have, of course, realized that it was going to be a problem based on lack of sleep and all that kind of stuff, you know. But I had that checked. I was hypogonadal, or at least potentially hypercortisolemic and all of that. And I didn't actually check my cortisol at that time. But I did go on injectable testosterone for a while, and I didn't feel much differently. And there's multiple reasons for that as well, which we're not going into today. But I figured out eventually that I needed to change my nutrition plan. And the way that came about was actually managing my type 2 diabetics differently. Because by God, I could not get them to improve their A1Cs almost no matter what they did, okay? And we were putting more meds and more meds and more meds, and we can go down the list of what we did up until we ended up on long-acting and short-acting insulin in these type 2 diabetics. And I want to go into that and why that's probably not the best idea. But I never really saw a lot of results. And of course, when you don't have time to listen, you chalk it up to non-compliance. So you add another med, right? Well, they must not be doing anything right with their nutrition plan. So we'll just put another medicine on board. And then if, heaven forbid, if they ever did something right, they would totally go hypoglycemic and, you know, pass out forever,
Yeah,
right? So anyway, it was actually a TED Talk that I heard that was going over, we may have to go into separate diabetic management for every single patient because, and I'm so sorry, but I forget the gentleman's name, but he was doing research on the, you know, putting a CGM, a continuous glucose monitor on, you know, 20 or 40 people, his study was, and he could show a different glycemic load on exactly the same amount of the same food for different people. So what that did for me was made me say, this is not good. My job is going to get so much harder if I have to fine tune everybody's diabetic medications based on their CGM. And that sounds like a cop-out, but it didn't make sense to me. And I thought there has to be something better. What is going on? So then I started looking into the actual recommendations. I've read a couple books. I looked into Dr. Jason Fung's diabetes code and Dr. Berenstein's type 1 diabetes management book, which has been around for decades. I mean, that guy's, you know, nearly 100 years old himself, and he's type 1 diabetic, right? So I started looking at these people who were having success, and well, why am I not having success? And it turned out that it was mostly the nutritional recommendations that I was making or that I was sending my patient. They were getting to a diabetic educator and they were getting those recommendations. And it turns out that they were being told that eating carbohydrates at a high amount was still okay, despite their type 1 or type 2 diabetes. And I mean, if you really look into the research and the success rates, that can't happen. And there's a reason for it. Okay. And then quickly I began to see that glucose is not the only problem. It is toxic in high amounts to cells, and we need to maintain that homeostatic level. But if we don't consider that insulin is half of the problem, we are not addressing it well enough. And that goes for both type 1s and type 2s. Of course, the type 1s don't make insulin anymore. The type 2s do. So it does change the management, but it doesn't change the nutritional recommendations. And so once I saw that and began to consider, well, if we do the right nutrition, it doesn't have to be everyone grab a CGM, figure out what, you know, whether a cup of ice cream makes your sugar 250 and the next guy's sugar only 140. Like, that doesn't matter anymore if we just get back to the basics of a low carbohydrate nutrition plan is probably best for almost every human being, especially for a type 2 diabetic, and I would say a type 1 as well. Okay. So I got into that mode. I was able to start using it in my patients who are type 2 diabetics, see some massive results, some actual reversal of their A1Cs, and then ability to discontinue or decrease their meds. And then also at the same time, I was doing a self experiment of would doing this sort of a nutrition plan for me as a non-diabetic, not even pre-diabetic, slender individual, would that be a good idea as well? And it turns out that most of my aches, pains, and issues went away as well, including, and believe it or not, people who are watching, my testosterone went from 260 to 880, and it was not overnight. It took a good 3 years to do that. But I had stopped the injections ages ago. And for me, the nutrition plan has been 3.5 years. And I've monitored it at least every 6 months during that time. So I have the progression of incrementally increasing those numbers. And then also it jumped quite a bit with more, not quite a bit, probably 150 points or maybe 200 with significant resistance exercise training, which I was finally able to get into a consistent regimen because of less frequent injuries, especially to my low back. So I'm 41. I look like I'm 81 because of this big
You
old
look
beard
great.
and bald head. But I feel like I'm, in my 30s again, and I can attest that many of my patients who've achieved that improvement in their, long-term illnesses and that sort of thing can say similar things, that they feel better. So.
Yeah, and I haven't necessarily seen pictures of you 4, 5, 6, 7, 8 years ago, but you're built like a man's supposed to be built. You're lean, you've got muscle mass, you look great, and it's just a reminder that and I tell patients all the time. I mean, we specialize in hormone replacement at our pharmacy, no doubt about it. But I tell patients all the time that is a piece of the puzzle. Nutrition and exercise is so important that goes along with it. And perfect example of you raise your testosterone, and you raise your testosterone by nutrition and by exercise. Your body doesn't, testosterone helps us to create lean body mass and, stay healthy and energetic and all those good things. But when you're eating bad, your body doesn't really want to produce testosterone because it doesn't think you need it because you're not performing like you need it. So it's great testimony. Thank you for sharing your story.
You're welcome. And I mean, we'll probably, especially when we ever get to the statin medications and things like that, I mean, the cholesterol itself is a building block to that hormone and many others. And if you have a vegan or vegetarian lifestyle, it is really hard to get some of that cholesterol. Well, and we say that the liver makes most of it. And so especially you taking the statin medication to inhibit the liver from making cholesterol, it's going to be a problem, right?
Absolutely.
And that cholesterol is part of the hormones. It's part of our every cell in the body. And so regenerating muscle cells after you've torn them down doing a heavy workout is really hard. Anyway, we'll probably get into some of that when we talk about statins and antihypertensives as well. So
yeah, we should probably devote an entire episode to that, Dr. Leavitt, because I would really appreciate your expertise on that, and I could talk forever about that. So let's get back to diabetes medication. So give us an example. Yeah, give us an example of a story of a patient that you have that they were on, a list of diabetic medications, maybe even insulin, and you were able to get them off that medication by helping them change their lifestyle.
Absolutely. So a couple different experiences, but one in particular stands out. This Latino gentleman who came to me because I am fluent in Spanish, and he had just been seen in the hospital for what looked like an MI. It certainly was not a STEMI, so he didn't have a stent placed or anything like that, but it was a non-STEMI. And he was started on a bunch of medications. He was started on metoprolol and a couple other, like a diuretic and things like that. He was also found to be type 2 diabetic, and his A1C was 13.2, right?
Whoa.
So his sugars had been high for a long time.
Yeah.
And so what happens in the hospital when you have someone with an A1C above 9? They're almost always placed on insulin, and they're discharged with insulin. And so he was also started on metformin while in the hospital. He was in there for 5 to 7 days and discharged to my clinic and established with me. Well, he also, you can look at it that he didn't really, of course he didn't know about the diabetes. It turns out he did know about the diabetes and had been treated in the past, but he hadn't been compliant with that, and so his A1C was so high, right? But he hadn't been on meds. So he was started on insulin, he was discharged with metformin and insulin, and then over the first hour of me meeting with him and educating him on what type 2 diabetes is and the problems of not only the sugar, because he had basically eliminated sugar, but what else do you think he was eating as a Latino gentleman? Well, a heck
Probably
of a lot of tortillas,
right? Right. Yeah, I mean,
right.
20 grams of carbs per tortilla.
Right. He and his wife makes the tortillas, and they're phenomenal, right? So this guy could pound the tortillas, right? And probably 8, 10, maybe more per day. So he's loading the carbs without really realizing it, or and then that term wouldn't have made any sense to him then, right? But with some education saying, it's not just the sugar, you've been focused on the sugar, but carbohydrates become sugar in your bloodstream, but also it is the insulin. And so within the first, we controlled his sugars for a while, and I didn't discontinue the insulin the first day I met this guy. But over time, when we were able to show that his sugars were going down with a better nutrition plan, I'll get to what I said here in a minute, but he was able to carefully cut back on that. And he was only on 10 or 20 units. So it wasn't crazy. I have other stories of people on 70, 80 units where we have to carefully, meticulously wean them down there. They're going to go hypoglycemic so fast, right? The guys from Verta Health, Steve Finney and his crew, they carefully wean people down in like 6 to 7 days, and they see a massive improvement in the A1C in that time, which most of us say, how is that? It's supposed to be a 3-month window. No, they actually see it that fast. But back to just spending the time with this gentleman and saying, okay, well, did you know that the refined grains that you've been eating, the breads, the cereals, the breadsticks, the pizza crust, the pasta, the tortillas, these are a problem as well, and you should avoid them at all costs. And if you do consume them, have it be much, much less than you're used to. Well, it didn't take long for him to do that. And within a month or two, we were checking A1Cs, and they were down to the 10 range. And then a couple months later, down to the 8, 7 range. The guy got down to 5.7 on his A1C.
That's non-diabetic. I mean, it's right? Wow.
Pretty much. My lab says 5.7 and to 6.4 is pre. And I check fasting insulin and the C-peptide on everybody, and also calculate their triglyceride to HDL ratio. And all three of those things tell me whether they're already insulin resistant. And I can pretty much just say that's pre-diabetes, whether your A1C is 5.1 or 5.7. I don't care. Because if your fasting insulin is 50 and your C-peptide is 5, it's a problem. And you're going to become diabetic before you know it. So you're pre-diabetic, in my opinion. Or in my patients, I say pre-diabetic just to make them feel a little better. But I do think it affects the prognosis as far how quickly they can reverse it, which I've seen a lot of. So,
out of curiosity, what did his fasting insulin come down to?
Ooh, I don't have it right off the top of my head. But of course, when he was on the insulin, I made that mistake one time of checking it. That was a dumb idea.
Was it sky high?
Yeah, 11.
Of course.
I'm thinking his C-peptide. No, that's not right. His fasting insulin, when the first time I checked, it was probably 33 to 40 or something like that. Yeah, when he's
on insulin.
And honestly, I've done a lot of those over the last 3 years, and they don't always correlate like patient to patient. They really don't. So one guy has it at 50, and his A1C, if they're already diabetic and they're not on insulin, his A1C might still be 6.4, whereas someone else whose fasting insulin is 30 might have an A1C of 12 or 10 or something like that. So I wish they correlated a little better. What I do is I look at everything in a broad picture and say, does this look like severe insulin resistance or not? And kind of move on from there.
And that's what's good about you being in a DPC environment like you are. So you can look at labs, they're not just black and white. You can look at the entire picture of the patient and say, oh, Yeah, I see what's going on here, and here's what we need to do. Instead of looking at it and say, "Oh, yeah, you're insulin resistant because your insulin's a little high, or your glucose, your A1C is a little bit high, so that means you're diabetic." Well, not necessarily, not all the time. So labs are a tool to go along with the entire picture, to go along with the symptoms
Yeah.
and the history and the entire body of the patient. So that's where you kind of have ahead of the game in a non-traditional practice in DPC, is that you can spend the time with the patient and go over all those labs and order the appropriate labs and interpret them appropriately. Correct?
Yeah, absolutely. And I'm willing to spend that time. And most of what you're doing there, though, I mean, I'm speaking for those of you physicians, but anyone really who's interested in how this works. You get a mid-belly circumference, so you measure at the umbilicus or whatever and see how large that is. You can compare that to their weight and that sort of thing. You can look at their triglyceride to HDL ratio. You can look at their fasting insulin, their C-peptide, their fasting glucose. We always look at that. Most of the time we look at an A1C. And you get a good feel for how insulin resistant this person is, or if they're pre-diabetic or type 2 diabetic. Of course, looking at the A1C is the gold standard. You can judge whether the full-on type 2 diabetes is terrible or not. But yeah, that whole picture, and those are most of what I use. And I find it pretty darn helpful, but just in convincing the patient, look, you have some evidence here that you need to change your nutrition.
Right.
And then I'll also say, so given that evidence, though, my experience is that if you do that, you can probably reverse this without needing a lot of medicine. And then I don't start a lot of anti-diabetic medications. I do like metformin and a few others, and we'll go into that right now. There
Please.
are some that I will not prescribe for various reasons, and I try not to prescribe a few others, but I will if the person has major issues with their blood sugars, right? So, do you want me to go into those
Yeah,
meds that I
please
like
do.
or don't like
Yeah,
or
please,
whatever?
no, please do.
Okay.
Let's start with metformin.
Okay. So, metformin is tried and true. It's safe for almost everybody unless you have pretty significant kidney failure. And then it's, of course, not used. I think it's a GFR of less than 30. Um, and I like metformin because it increases insulin sensitivity. It does not tell the pancreas to make more insulin. It doesn't trigger a worsening of the hyperinsulinemia. Okay, of course, it's not used in type 1 diabetes. Let's just focus on type 2 for now. And anyway, so meds that improve the body's response to insulin begin to improve the solution to type 2 diabetes, at least from a pharmacological standpoint. The
Right.
best solution is to get rid of the damn sugar and carbs, right,
Right.
people? So
Well, that's
the
one thing.
best way,
If you'll just let me go for just a minute on that.
absolutely. I can derail because I'm really passionate about this. I'm sorry, Shawn.
Yeah,
Go ahead.
and well, no, you don't have to apologize at all. But I say it over and over again. Diabetes mellitus is a carbohydrate metabolism problem. Period.
Right.
Diabetes mellitus literally means honey siphon. Siphon. It literally means that you are urinating out sugar in your urine. That's literally what it
Mm-hmm.
means in Greek. Now, um, whether it's type 2 or type 1, they are both carbohydrate metabolism issues.
Mm-hmm.
Yes, they are treated differently, but still, I want to make it clear because in traditional medical practices, traditional medicine, we think, and you mentioned it at the first of the show a little bit, that type 1 diabetes is treated completely different and you should just eat all the carbs you want necessarily and just use more insulin. And you hit on it, Dr. Berenstein hits on it. That is
Mm-hmm.
absolutely not true. Whether you are type 2, if there is one thing, in my opinion, that you can get from this show, and I don't know about your opinion of this, Dr. Leavitt, but if there's one thing that you can get out of this show is that type 2 and type 1 diabetes, you have to monitor your carbohydrate intake, and probably the lower carbohydrate intake you have, probably the better. Is that correct, Dr. Leavitt?
Almost certainly, I wholeheartedly and almost certainly the lower the sugar and grain and every other carbohydrate intake that you can do as a type 1 or 2 will be safer for you in the long run. Now, if you're on insulin or some other medication that will take you very low in your sugar, if you don't keep eating a high carbohydrate load, then you need to either stop the medication, or of course you need to talk to your physician and lower the medication as appropriate so that you don't cause yourself problems by eating a great nutrition plan and yet taking a medicine that's for generally people who don't eat a great nutrition plan. Okay, so be careful with that, folks, if you're listening for yourself. But those of us providers, be willing to titrate people downward, wean people off of those medications carefully when they're making amazing nutrition choices, which is for any type 1 or 2, eliminate the carbohydrates, people, because they are toxic to your system. Yes.
Yep.
Eliminate. And if you haven't looked into the fact that carbohydrates are not essential, you probably should. There's a lot of physicians out there giving lectures and things like that on that carbs are more addictive than they are helpful. They're not an essential part of human nutrition, and we can live without them very healthily, especially as diabetics. Okay. So, and Dr. Berenstein's book goes into that. He definitely allows for some. He doesn't tell everyone to eliminate them entirely. And there are some documented benefits of, plants and the micronutrients you can get from them, and some of the benefits of fiber, which isn't necessarily, constipation driven or, bowel movement, like helpful for bowel movement and things like that. It's not just that or only that. But anyway, so yes, carbohydrate processing or metabolism issue, totally on board with that. And the lowest carb nutrition plan for a diabetic, or really I think any human, just so we don't become diabetic, is the smartest thing. And I've seen it work. And unfortunately, that's not the most common way to approach the management of both of these conditions. And that's kind of where I see our conversation helping providers and other people to maybe change that, or at least consider looking into it. Okay. So
absolutely. Thank you for all that. You're an inspiration when it comes to this. I love seeing, I love seeing doctors that actually, go to the root of the problem. I mean, let's fix the problem. In general, diabetes is not necessarily type 1, but type 2, it's a nutrition issue. Nutrition and possibly lack of exercise, but nutrition is the most important. So let's fix the problem. Let's just don't treat the symptom of high glucose with another medication, right?
Right. Yeah. And real quick, before we get to the other meds for type 2, type 1, if you are a provider, or if you have a family member who is type 1, or you're type 1 yourself, really go back and look at what those recommendations have been as far as the glycemic or the glucose recommendations from your diabetic educator or your physician, and question whether it needs to be as high as it is. The last one that I looked at came across my desk maybe 2-3 weeks ago. 45 grams of carbohydrates per meal for my type 1. Per meal. I kid you not, per meal. And it blew me away. And
for an adult patient?
No, this is a teenager.
Okay. And active? Yeah. Was he super active? He or
pretty
she?
Active, but yeah. Honestly, does that matter, Shawn?
Well, I get it.
Right. No, it doesn't actually. I mean, if the person were to wean down on their insulin, so they're not going to overdose on insulin and not wake up, right? If they were to wean down on it, yes, they may require a little extra insulin, but they're going to know about it, because if they're taking their, like Dr. Berenstein gets people down to, their 3 units of NPH, twice daily or something like that. By the way, have you ever heard of that in type 1 these days? No, you haven't. There's no way, right?
Right. Well, I will say this. I have a twin brother with a son. He's 21 now, and he's type 1 diabetic, and he uses 10 to 12 units of insulin a day.
Nice. I love
And
it.
he followed Dr. Berenstein's book. That's how I learned about him, was from my twin brother Shane. Well, so let's move on. We've talked about insulin a little bit. We've talked about metformin. Let's talk about some of the other medications that you prescribe for type 2 diabetes as we wrap this show up.
Type 2. Okay. No problem at all. So by and large, what I use has to deal with improving the insulin sensitivity and trying to reduce the amount of insulin that's in the system in a type 2 diabetic. Because just like we've alluded to before, the higher the fasting insulin, the higher the level of insulin in the body is a problem. It's half of the problem in diabetes, and it's the half of the problem that's usually forgotten. We overly focus on high sugars and how they are toxic to cells, which is true, but we don't focus enough on elevated insulin causing insulin resistance in all of the cells of the body, which basically makes them very non-functional. And you can think of just about every symptom that can go wrong, and hyperinsulinemia causing insulin resistance can cause those symptoms, okay? It is one of the things that causes peripheral neuropathy that I've observed in certain patients that they're not even type 2 diabetic yet, and they have significant insulin resistance. So their sugars haven't been in the 250 to 300 range for years, causing numbness and tingling in their hands and feet. And yet they have the symptoms, and it's because they are hyperinsulinemic, and those nerves are not working very well. So think about that from all the tissues of the body. If you have elevated insulin and now your body doesn't want to use the insulin for the many functions it provides, then you're insulin resistant, and you will be unhealthy because of it. Your cells won't work very well.
Yep.
So think about that when managing and being type 2 diabetic. Reduce the amount of insulin. The best way to do it is not eat foods that increase your insulin. It's super easy. It's cheap. It's affordable to do. You just don't buy the junk food. Okay.
Right. Right.
It's a freebie, right? And that's the best way. But from a medication standpoint, metformin, the thiazolidine so the TZDs like pioglitazone, they also increase insulin sensitivity. The SGLT2s, they decrease the glucose absorption. And wait, let me go into that in just a minute. Hold on. Yeah, that's the only other one that I like. It actually doesn't improve insulin sensitivity, though. It just doesn't allow you to absorb as much sugar if you choose to eat it. But I try to tell people, if they are going to choose like Farxiga or those other super fancy meds in that class of the SGLT2s, that they would be better off and they would save a lot of money if they didn't just eat the sugar in the first place.
Well, right? Those drugs essentially make you urinate out the sugar, right?
Right.
And
don't they decrease the absorption in the intestine as well? You're probably better at the actual pharmacology than I am,
they do that also. But again, like you say, just don't eat it.
Right. I mean, if I personally, since my health share that I have for me and my family would never pay for Farxiga or Victoza or any of those meds.
Yeah.
Then I would never pay $1,000 a month or $500 a month.
Right.
When I could just buy, a bunch of ribeye steaks instead. I would totally love that, right? So,
right.
And they don't have any sugar in them, so I would be just fine eating that and only that.
That's right.
Instead of taking Farxiga and eating a bunch of Snickers bars, Pop-Tarts, and ramen. Okay, people, like it's a thing, and so that's why we don't want to eat those foods that would just make us need to take a medicine like that. The same goes for meds that I will not prescribe, not only because of high cost, but even affordable insulins and things like that. Like, you want to do as little as possible. Let's get to the meds and then the insulin. But things like the GLP-1s, Victoza, Trulicity, those sort of things, they increase insulin secretion, and they're really expensive medications, really expensive. Affordable pill medications that are also, in my opinion, not great for type 2 diabetic management are the sulfonylurea medications. They also increase insulin secretion. They're insulin secretagogues. That's what they do. Yeah. And they're also very prone to cause hypoglycemic events. And what happens is the person forgets to eat the carbs, and then they go low because they have a whole bunch more insulin than they usually do, even though they're always pretty high in insulin. Still, just like when you inject insulin,
Right.
the more insulin you get, the lower your sugars will go. But the problem is insulin is still part of the bad problem. It's not just the sugar that's the problem, people. Okay, and then insulin itself, when I prescribe it, I try to do inexpensive forms. Of course, some people's insurance will cover it, but I don't agree with just willy-nilly prescribing and having the insurance pay for it, because then all of us end up paying higher premiums for our insurance and things like that. So that's a topic for another day that Shawn and I definitely share opinions or share, our thoughts on quite a bit. But I prescribe NPH when I do. I may do a low dose, long acting, but I can't really find affordable options a lot of times. So I'll do, Humalog and Novolog as well. But to try to keep the costs under $100 a month, the best thing for the patient is to just not eat the carbohydrates and then not eat as much insulin. So it all goes back to that nutrition plan,
It does. I mean, we talk about all the time, Dr. Leavitt, about how expensive diabetes is and how the government needs to get involved with which making insulin less expensive and making it affordable. And the reality of it is, I mean, you just said it. If you eat right, you don't need insulin. Now, I get it with type 2 diabetic. With type 1 diabetic, it's a little bit different, but we just talked about a type 1 diabetic that can treat their diabetes with 10 units a day. So you don't need 100 units. So that's going to save you tenfold in money. And like you said with the NPH, when you prescribe NPH and regular insulin, which has been around since 1983, you can get them for $25 a vial at Walmart. So at 10 units a day, 1,000 units in one vial, that's 100-day supply for $25 if you're using 10 units of insulin a day. Diabetes does not have to be expensive to treat if you have proper nutrition and are prescribed the correct insulin. Correct?
Absolutely. I agree. And then even with, I mean, I guess we already said it, but even with our type 1s, as long as you're careful to not be taking too much, you're just avoiding, you're doing the same exact nutrition plan as your grandparents are doing for their type 2, but you've got your type 1, right? And you're being really cautious to not overdo it on your insulin. But so those people who are already on it, make sure you go down slowly with your physician's help, get a physician who is willing to do that, and you're going to be just fine. But anyway, so there are a few other meds, but I rarely prescribe. Honestly, I've been able to control almost all my diabetic patients with metformin or one of the TZDs. And if it gets, and none of my patients will actually be able to pay for an SGLT2 or DPP4 or GLP-1s because they're so cost prohibitive. And they all pay me cash per month, and it's usually because they don't have an insurance that they rely on to pay all of their medical bills. Okay, so and then I do have patients on insulin. I'm not against it, but I have to educate. I don't feel good about myself if I don't educate excessively every time we talk about their diabetic management. Like, what are you eating? Please send over the last 2 weeks of what your log is. I have them keep track, not always, but for a few week period, send it my way. I look at what they wrote down. I'll even look at the labels of certain foods that they say, well, what do you think of this, doc? And so they'll send over the ingredients, or a lot of times they send over the carb thing, and I still have to have them resend a picture of the actual ingredients, and can be helpful. And I offer my thoughts on those things. And usually if it's a processed, packaged food, there's a problem there somewhere. Right. Not always, but not always. Anyway, and folks, so I've seen a lot of results with this, okay? These people, just by changing the amount of sugar and grain that they're putting in their bodies, they are making improvements in their diabetes. And I have been able to de-prescribe a lot of these medications, particularly insulin. In the rare case where someone is on one of those really expensive diabetic medications that I don't agree with because it increases insulin, then I'll discontinue those as well, and maybe start that TZD pill, or I can't even think of a case where I started an SGLT2 rather than discontinued. But anyway, any med that increases insulin sensitivity, and any diet plan that decreases insulin production is the right way to manage type 2 diabetes. And really type 1, but of course you're not going to do the other pills that are not, you know, in a pancreas that doesn't produce insulin anyways. So,
but
anyway.
I mean, you said it, a lot of those expensive medications just aren't necessary. I mean, if you have a doctor like yourself that is teaching people how to eat properly and monitoring that, you don't need expensive medications to treat diabetes.
Right. Yeah, and
Dr. Leavitt,
if the med's going to be a fortune and it just increases your insulin production, there's no difference between, like, safety-wise, there's no difference between that and just starting insulin. You have to inject it anyways, right? Maybe you only have to inject it once a week or whatever, but or just once a day instead of multiple times a day. But I would argue to the patient and say, you know, if you're going to do that, and we've really struggled, there are a few, you know, late onset type 1s or people who just completely burn out their pancreas and now their C-peptide is low, which is rare in a type 2, but it happens. I've seen it a few times. Then I am going to go to a very low dose insulin, okay, and treat them kind of like a type 1 diabetic.
Yeah.
And then the meds that increase insulin will not work in those patients because they do work on the pancreas and they increase insulin production. And if their C-peptide is 0.2, they will not respond to GLP-1 or a DPP-4.
Because they don't have any of their own insulin. They can't make their own insulin.
Well, their pancreatic beta cells are unable to produce it. And so increasing the synthesis just doesn't happen. It cannot happen. No. So you can't make more cells. It's like they went type 1, even though they're still type 2. So
Right. That's good that you monitor those things. So, Dr. Leavitt, lots of information today on treating diabetes, and I love it. I love your approach to it, and we're all about, you know, fixing problems here, not just treating symptoms with medications. So, as we wrap this show up, what do you have a passion for, Dr. Leavitt? What's your passion?
I think I've talked a lot about my clinical passions here, like spending time with my patients. Enjoying a better patient-physician relationship, getting to know them. And when I meet for that first hour, you know, I ask people about their hobbies and interests and what they do for fun. You know, how does their mental health stay well, that sort of thing. And then for me, sometimes I'll share mine if they're, you know, similar to those patients, so they can kind of see that I'm a normal person as well with hobbies and interests. And I love to spend time in my shop. I have some woodworking equipment in there. I'm pretty amateur, but if you came to the clinic, and you actually have, Shawn, but you would see some countertops and things that I've made in my woodworking shop that are here in the clinic. What else? I do a little disc golf. I do a little bowling. I love sports that require accuracy and precision. So
that's why you're a doctor, right?
I'm a former competitive archer. My family did archery as a kid, and so we competed in summer games and stuff like that. So I gravitate toward those sort of activities. But my spouse, Angelique, and our 3 children, we love to hang out together. We have a great, home life. Things are great. I have a lot of passion for living, and, you know, I hope that I kind of embody that and show other people around that life is fun and it's worth living. So.
Yeah, you definitely do. I mean, it shows in how you practice medicine. So I appreciate it. You're welcome. You've definitely reached our goal today of educating and empowering consumers to take charge of their own health, and I really appreciate that. So, Dr. Leavitt, what is the best way if somebody has questions? How do they get a hold of you?
Contact my clinic, Nampa Direct Care, and it's at nampadirectcare.com. And the phone number, if you want to contact Jane, my general manager, it's 208-252-9404. It's all right there on the website. Check that out. We have FAQs in there of how the clinic works. I mean, generally, it's a thing where if you're an Idaho or Oregon resident, it makes better sense just because you're closer to me. But if you need to, you know, bounce ideas off me, my general manager can get you in touch with me via phone call or something like that. So, I mean, most of my patients end up signing into or becoming a member of the clinic, like I said at the very beginning, and paying a monthly membership fee rather than a per visit payment. And that's how I run my clinic.
Awesome. I love it. So we'll have
you can
to
also
schedule.
Email. It's on there. nampadirectcare@gmail.com. That actually goes to my office manager, but she's really good at triaging those and seeing who needs to be addressed faster rather than slower, and we get answers out to those folks as well. Okay.
So we got so deep into diabetes today, we didn't get a chance to talk about high blood pressure medications and statins. So we will have to schedule you on again so we can educate our consumers again, our listeners and viewers on the ins and outs and how to possibly get off their other medications. So thank you so much, Dr. Leavitt, for your knowledge today. I really appreciate it. And thank you, listeners and
You're
viewers,
very
for tuning
welcome.
in. You're welcome. Thank you, listeners and viewers, for tuning in today. So this week, Thursday, there is no podcast because Jan and I will be out of town, and Jan and I will be also be out of town Monday. So we're going to take a little bit of a break from podcasting for a while, but we will be recycling some episodes, and stay tuned because we're going to be really active down in Moab. It's a mountain biking mecca down there, and I've got a 3-day stage race that I am excited to be a part of, that I've been training for 2 years now, but it's gotten canceled a few times. So I'm excited to go down there. So stay tuned. Watch this on Facebook, the Moses Lake Professional Pharmacy Facebook page and my personal Facebook page, and you can see all of our adventures. So thanks for listening and tuning in to Health Solutions with Shawn and Janet Needham.